We are going to use this little dry needle today in my pelvis, hopefully so that you don't have to. You can avoid pelvic floor dysfunction, but I'll take one for the team and get it done on camera, so. Hi, I'm Reese Rulin from the Pros Closet, your host of Live, Laugh, Learn, the series where we talk to experts to help you become a better athlete and cyclist. Today we're here at OnWard Denver to chat with Kelly Sammis about pelvic floor dysfunction, which I don't think a lot of people know what that is, but it actually might be affecting you negatively. So we're going to chat with her about why you don't want that and how you can fix it if you do have it. All right, we're here with Kelly Sammis of OnWard Denver. Tell us how you got into pelvic floor dysfunction and physical therapy.
So I got into pelvic health originally because I had pelvic pain myself. I was already a practitioner, and I started experiencing what I thought was just this persistent hip, low back pain, and suddenly I started having pain with intercourse. And as a practitioner, I didn't go see anybody for that. I just went to my first course to self-diagnose and figure out what the hell was going on in my body. And so I realized really quickly on that course that what I thought was this persistent SI dysfunction, hip dysfunction, was really my pelvic floor. And being an athlete way back in the day and starting to continue that into my adult life, I realized that there's more to this that I didn't even understand. And I was in the healthcare arena and in the PT arena. And so I started realizing I need to learn more, I need to know more, and I need to know how this impacts my athletes. And that kind of started my journey into pelvic health and sports performance.
I mean, I had no idea the pelvic floor was an actual muscle. Like when someone says pelvic floor, in my head, I'm like, this is like this abstract thing that's just the bottom of my hip bones.
So let's just talk about what the pelvis role is. So truthfully, the role of the pelvis and how it relates to human function is that it's our load transfer system. So it's our epicenter of load transfer from one extremity to the other, but also from the bottom half to the top half. The second thing that it does is it's force production. And so because that load transfers through the pelvis, it's how we generate power. So you think about that in cycling, how you generate power in your stroke, it's got to come through the pelvis. The third thing it does is postural aptitude, or it's just part of our stability system, which lends us towards the rest of the muscles it works with. So the pelvic floor is just part of an entire system. And I think that's why it's so important to understand that it's not standalone. It tends to get people's attention when it's symptomatic, no doubt, because it's part of what contributes to your incontinence or your leakage. It can be this persistent pain that manifests like it did for me in terms of painful intercourse. For men, it's penile pain, scrotal pain, but it's really just part of a bigger system. So we consider it the core canister, and it's the bottom of the core canister. Okay. Top of the core canister is the diaphragm, which is why we have to look at breath mechanic, we have to look at bracing strategy, we have to know how an athlete's controlling what's called intra-abdominal pressure. The front of the canister is the abdominal wall, and it plays a huge role in that control of IAP or intra-abdominal pressure, as well as how we recruit. Then the back of the canister is the low back. And that's why if there's dysfunction somewhere in that system, usually the pelvic floor is the one to overcompensate. It kind of goes on this high tone, tight spasm because gravity wins, right? It's the bottom of the canister. So if there's dysfunction somewhere else in the body, this is the one that usually compensates.
All right, so I have some questions. So I guess what do you normally see in cyclists? What happens within the pelvic floor? Why is there issues? What are the main ones?
I would say you've got two different things that you're going to see. One is going to be more of a coordination issue, which becomes a pressure management dysfunction. So you're going to see things like prolapse. You're going to see things like urinary incontinence. So we see this a ton in not only our endurance athletes, but also in our resistance training athletes as well. The other thing that you're going to see is pain. And so that looks a lot of different ways in terms of how that pain presents itself, because we have this nerve that actually comes from these three segments, so 2, 3, 4. It goes into this notch and then dives back into the pelvis, so it comes out before it re-enters, which automatically kind of predisposes it to dysfunction, and then it lives within this canal that's between ligamentous structures and then more specifically what we treat, the musculature. as it kind of enters the pelvis, it starts to branch. And so 3 different branches of it are going to be the rectal branch, one that comes to the perineum, and then it will come into the labia for women or into the scrotum for men.
So this is a male and female problem.
Absolutely.
Doesn't matter.
Men have the exact same musculature of the pelvic floor, with the exception being this particular one here that's just obviously closed and it extends up the shaft of the penis. And that's probably what I see the most in cyclists in terms of pudendal neuralgia or cycling syndrome, is compromise up into this last branch, which is the dorsal branch. So it goes to the penis in men, it comes up to the clitoris in women, and it can feed into a little bit of the labia as well. But if you think about when you get into really aggressive riding positions on a bike and on a saddle, it can put a lot of pressure right on this ischiopubic ramus, and that's where that nerve lives. So not only do we see this pressure mismanagement, coordination issues, but then it can manifest as pain as well, which can be very challenging to know where it's coming from. A lot of our athletes experience even like the onset of some of these symptoms, but they don't think, oh, this is something I should consider talking to a PT or a rehab professional about. It's just especially in our pain syndromes, it's well, I had an aggressive ride, so that was good. Like a little numbness and tingling, ain't no thing. But then it starts to progress itself to pain syndromes, and you end up in kind of that medical community where they're offering you these more aggressive treatment options because the knowledge base isn't there, that it's actually a musculoskeletal issue. What ends up happening is gravity wins, and so it comes right down into the pelvis and into the pelvic floor. Aggressive riding position, plus you're doing all of this core work with maybe a poor breath strategy.
100%,
right?
absolutely.
To where it's this
don't breathe.
Constant push into the pelvis, and finally it's like, oh my gosh, what are you doing? And it just keeps tightening up. And the pelvic floor reacts to that by going into like protect mode, essentially. Okay. So it spasms, it tightens up, and it's like, wow, that's a lot of pressure coming down, what's going on? So it can't support you. Part of its job is stability, and it's support of our organ systems. So rectum, and then you've got bladder, and then you've got your uterus, all these things in females, obviously, but it's a mismanagement. And so then that particular muscle group can't support it. And you feel that. You feel that foreign body sensation, or that like sensation of something is falling out.
Yeah.
And usually it's just, we need to reset the coordination of the entire system.
All right, walk me through what my pelvic floor and my pelvis are doing as I go through different positions.
Yeah, so ultimately we want to get a lot of the actual pressure onto the bony prominences. Okay. So oftentimes you see, if you're riding on the wrong saddle, it's going to put pressure differential right onto the soft tissues, or it's going to fall medial to the actual sits bones, and that's where that little canal is that the nerve lives, so it can be really compressive. So the first thing is make sure that you have a saddle that is supporting your pelvis, right? And so then you want the sits bones, you want most of that pressure coming through the bony prominences, but what ends up happening is if you have shifts in the saddle or you're changing riding position, then it's gonna bring the pressure to different places on the pelvis.
Got it.
The more aggressive the riding position, the more you can start to approximate that dorsal branch right on this little bony ramus. And that dorsal branch just lives right here. So let's say you're too far forward and you're in a really aggressive ride position. Then all of a sudden you're putting a ton of tissue compression onto that dorsal branch of the actual nerve.
Yep.
So that can start to give you some of those labial, clitoral, or for men, penile pain. If you're too narrow on your saddle, or you've slid forward and you're kind of coming into more of that trunk, that can be more of that labia pain, perineal numbness, tingling, scrotal pain for men. So really, it's trying to get the pressure where it needs to be and offload the tissues that can be really disruptive in terms of a symptom. So if you think about where you are in different positions on the actual handle, then you're going to continue to kind of come into that anterior tilt.
And my spine would be...
And your spine, a lot of times, will dump into more of that over-curved posture, right? And then it puts a ton of stress on posterior chain. So if somebody's really tight in the hamstrings, it can start to feel like a pull as you come into more of those aggressive riding positions.
This feels familiar.
Might feel a little familiar.
I know a friend with a similar
Yeah, I'm sure. It's a good friend.
and a close acquaintance.
Yeah, very close. So the other piece to that then is once we've got the right saddle, we're in a good ride position. So the height of the handlebars, the height or the position of your saddle, all of those things matter in that piece. But then we have to talk about load management. And pressure management through the actual pelvis. So breath becomes a big thing, especially if you're in this trunk flex posture, so you can't actually get into good diaphragm recruitment. So a lot of it is trying to work into that breath strategy in riding. And that's going to change based on the challenge of your ride. So I usually tell my athletes we work off of that rate of perceived exertion. Like how hard are you riding? If you are in this like 0 to 3, 4, where you're like, I could do this all day, no effort, like minimal effort, you should really be just in that diaphragm breath. No recruitment on your exhale. If you're starting to get into that moderate intensity, you're like, all right, I've got some road underneath me, or I'm starting to get into a little bit of a climb, and I'm in that 4 to 6, 7. All of a sudden we want to get into that breath cycle where you're like getting into diaphragm on the inhale, recruiting into the abs on the exhale. Then we toggle into, all right, this is hard. Like I am in like my max exertions, I'm 7+, I'm in this challenge. I don't want to just let go of my core. So you have to keep this little recruitment, which makes us have to get lateral costal expansion. And so for many athletes, especially that don't know how to let go of the abs, that's tough. So you're already in this flex posture. You can't get into rib. You have extra pressure on the perineum in places you don't want pressure.
We're pushing down.
Sometimes it creates a perfect storm. Right? So a lot of it is just kind of stepping through treatment. We want to start to get better coordination, better mobility through the tissues, reset those tissues, repattern how you're using them, and reload it so that you can do what you love.
Just to clarify for our audience. Slam stem is not always the best option. It might look cool, it might make you look like a racer, but sometimes you're going to hurt this bad Larry over here.
And it doesn't mean you can never do that. Sometimes it means we've got to modify while you're in like a symptom magnification. We modify posture, we modify the bike to get you back to pain-free or symptom-free riding. And then we learn coordination and we work ourselves to things like that in terms of posture. So it's not a never do it kind of thing. It's a let's make it make sense for your body.
I love shopping at the Pros Closet.
All right, so we are going to come into the dry needling piece to your treatment. So one of the reasons why we end up seeing a lot of pelvic floor dysfunction start to manifest as other things is because all of these things have to work together. And so it's not uncommon that we have to come in and treat the spinal musculature, come in and treat anything else that attaches to the pelvis, which is realistically anything from the chest to the knees. Right, so today we're going to focus on, because Reese has a couple other things going on in terms of that posterior chain, so we're going to focus on her low back and hamstring and start getting some treatment in with dry needling.
I'm looking forward to it.
It's going to be good stuff.
This one's pretty good right now.
You know, I consider it nourishment to the tissues. It's what your body's craving right now. Give the body what it wants.
Honestly, I was thinking like a glass of red wine.
You know, you can
and
do
a massage.
That too. I oftentimes have patients request a bar is present in our clinic, but alcohol and healthcare, you know, it's frowned upon.
Oh yeah, that feels good.
It's good stuff. It's good stuff.
I like that.
So then we're going to create a little circuit. So a little circuit from your low back down into that posterior chain. So what we're going to actually see is some nice motor recruitment to get the reset that your tissues are looking for, especially this pesky hamstring.
This feels good. I like this.
All right, so what I'm gonna have you do, I'm gonna turn on your low back first. So I want you to tell me when you feel like a heartbeat in the muscle. So you're gonna feel it contract and relax. You're not going to be doing it. We'll likely see it here too. So you just let me know as soon as you feel that. Good.
Good.
Okay, and then down into the hamstring.
Oh, geez. Yeah.
There it is. Good. We're getting a little
Christ.
bit. We're getting a little of your interface with your.
I love this.
I love it.
Oh my God.
All right, so you're gonna feel it's gonna go fast to slow. So we're kind of sweeping through different frequencies. So you'll feel it be a little bit of a slower beat and then roll into a little bit of a quicker beat in the muscle. Tolerable at that intensity?
Oh, yeah. The relief, it's funny. So after I get dry needled, I'm immediately sore and I feel terrible. And then that goes away within, the afternoon or something. I do like a quick spin or something. You're like immediately sore and you feel like you did like the hardest workout of your life just laying here. Whatever the stimulation is or whatever it releases ends up making your problem kind of feel like it goes away pretty quickly, at least with me.
So a lot of times when we're treating pain conditions, we want to modulate frequency of the delivery of the stim. And what's most meaningful is to do a little bit of that like lower frequency. And then ultimately we would want to get up to a higher frequency where it takes the muscle into like almost a pseudo-tetany, to where it's coming into this like grab for a few seconds and then it lets go back to that slower beat. And so we're going in between different nerve fibers when we do that with the frequencies. So it just lends towards better muscular performance ultimately and a better reset mechanism for the tissues.
Thank you so much for dry needling me, even though it was like a good pain. You've walked me through kind of the techniques of breathing and how that, influences which direction you're going. What are ways, like what's the next step? Like what happens next?
So once we get an athlete out of that acute, subacute injury phase, then maintenance is key. But in all of these phases, we're really looking at the principles of reset, reinforce, reload. So we want to reset the tissues, and sometimes that can look like the dry needling for the reset. Other times it can look like soft tissue work, myofascial release, any of your tool assisted. So sometimes people will use scraping or cupping or any of your other fascial tools for that particular reset. And then we want to reinforce the tissues. So reinforcement looks like good movement strategy. So it's a lot of your mobility drills. It's a lot of your coordination drills. It's the stuff that athletes don't like to do because it's not as fun as what the reloading looks like. And reloading really could be as simple as, let me get you back to your sport. You need that cross train with reloading, which looks like resistance training. And it's resistance of those muscles or those tissues that aren't as optimal. They're not as efficient. And so a lot of times if we can get you into that realm and that arena a little bit more, longevity of symptom relief comes.
And the last thing, I think, just knowing, it was so demoralizing hearing that like, I'm not going to be able to do my sport anymore.
Right.
And so I think if, hopefully people will watch this and someone somewhere will feel like, oh my God, I know someone, or oh my gosh, that's me. But I guess like, what would you tell someone that is experiencing some kind of pain, whether it's like the IT band that you were talking about, where that could be a symptom of pelvic pain? Like, what would you say that like, to encourage someone to go seek help, and that it's not like it's not the end of the world?
I would say the biggest thing is don't lose hope. Because it can be and feel catastrophic, especially when you get pulled from something you love, pulled from your sport. And then it's find the right community. Find the right community where hope is really kind of the foundation of it, to where there are positive treatments that can influence the tissues, that can get you back to doing what you love. It's really tough because there is a lot of negative surrounding some of these different diagnoses, and so Dr. Google isn't really the best place. And so it's really, don't lose hope, find your community, and there are so many great resources out there, especially for the cycling community. And so you just have to find that provider, find that community, and you can get your treatment to get you back to doing what you love doing.
Awesome. I mean, thanks so much. I hope someone else finds this as helpful as I have, and everyone, you are heard and you can get back riding.